are also risk factors. There is I am Dr. Robert Jones, and this lecture is an introduction to abdominal aortic ultrasound. Abdominal aortic aneurysms are an abnormal full-thickness dilatation of the aorta. Risk factors include atherosclerosis, smoking, hypertension, male sex, advancing age, and hyperlipidemia. A family history of abdominal aortic aneurysms and the presence of congenital disorders such as Marfan syndrome and Ehlers-Danlos syndrome are also risk factors. There is an associated high mortality rate if rupture occurs. Therefore, it's essential that an accurate diagnosis is made early in these patients. Physical exam is unreliable for making the diagnosis of abdominal aortic aneurysms. Obesity is a major limiting factor. It would be nice if all patients with abdominal aortic aneurysms, such as the one in this video, had such an ideal physical exam. It has been estimated that only about 50% of patients with leaking or ruptured AAAs will have the classic triad of back pain, hypotension, and a pulsatile mass. Patients can present with symptoms suggestive of renal colic or other intra-abdominal pathologies. They may present with syncope, chest pain, or even back pain that sounds muscular in origin. Therefore, since patients can present with a variety of symptoms and findings, misdiagnosis is a real concern. This patient presented with findings suggestive of diverticulitis and underwent CT scanning where a ruptured AAA with massive retroperitoneal hemorrhage was diagnosed. You can see here you've got the very large abdominal aortic aneurysm, and to the left here you can see the very large amount of retroperitoneal hemorrhage. The goal in the evaluation of these patients is to rapidly diagnose them so that they can be emergently taken to the operating room. This is the best way we have in order to minimize morbidity and mortality in these patients when they present to the emergency department. The use of bedside ultrasound can be used to rapidly diagnose the presence or absence of an abdominal aortic aneurysm and provide more rapid patient disposition. Prompt recognition and emergent surgical management are the key factors in reducing morbidity and mortality. The use of bedside aortic ultrasound in the at-risk patient should be done liberally for these reasons. Remember, up to a third of these patients are initially misdiagnosed. This patient who presented with back pain was found to have a large abdominal aortic aneurysm and was also found to have evidence of rupture. She was emergently taken to the operating room. This concludes the introductory video. Now move on to the next video. I'm Dr. Robert Jones, and in this lecture we will be covering how to perform the sagittal abdominal aortic ultrasound examination. Let's first look at exam essentials. Let's begin by looking at transducer selection. The exam is usually performed with a 2 to 5 megahertz transducer. Remember that in the decision of what transducer to use, you're dealing with two main issues. Number one is how far is the target organ within the body? That's going to be related to what frequency transducer you're going to use. The more superficial the structure, the higher the frequency can be used. In the average adult, a higher frequency 5 to 10 megahertz transducer will not provide adequate penetration in order to visualize the aorta. Therefore, you're going to need a 2 to 5 megahertz transducer to accomplish this scan. Now, the other question becomes, do you want to use a curvilinear array or a phased array? Any of the three transducers here will work in terms of performing an abdominal aortic ultrasound exam. Here you have the phased array transducer. Here you have a small footprinted curvilinear, and the footprint refers to the portion of the transducer that contacts the patient, and here you have a large footprinted curvilinear transducer. Ideally, the large footprinted curvilinear transducer should be used if available, since this transducer will aid in displacing bowel gas and is much easier to use for the abdominal aortic examination. Let's now look at patient positioning. The exam should be initiated with the patient in the supine position. Additional windows are frequently obtained during elective scanning of the aorta, with the patient in either the right or left decubitus position or the right or left posterior oblique positions. However, in the acutely ill patient with suspected leaking or ruptured AAA, these windows are infrequently performed. For elective scanning, it is also preferred that the patient be NPO for approximately 8 to 12 hours. This is not practical in the ED, and scanning should be performed regardless of the prandial status. Transducer pressure. A common reason for not visualizing the aorta is the presence of overlying bowel gas. Application of gentle transducer pressure is often needed to help displace the bowel gas and improve visualization of the aorta. Note in this patient that initially the aorta can't be visualized, and it's only visualized after transducer pressure is applied. So remember, if in the beginning all you're seeing is dirty shadowing from bowel gas, apply gentle transducer pressure, and that may be the difference between seeing nothing to visualizing the aorta. Even patients without evidence of atherosclerotic disease of the aorta will have some degree of ectasia of their aorta. This means that you can't just take the transducer and move down the abdominal wall in a straight cephalad to caudal direction. Basically, what I'm saying is that it's not like unzipping or zipping your coat. You're not going to go up and down in a directly straight plane. The technique that's used to scan the aorta is called the rock and glide technique. You can see here that this technique includes gentle side-to-side movements as well as angling of the transducer so that visualization of the aorta is maintained. Note in this patient with the normal aorta that gentle side-to-side movements as well as transducer angulation was needed in order to maintain visualization of the aorta. You can see right there that some movement from side to side occurred as the aorta was followed down caudally. Now, in patients with atherosclerosis, the degree of ectasia may be greater, and therefore greater transducer manipulation will be required in order to follow the aorta from a proximal to distal direction. Note in this sagittal image that it appears that the mid portion of the aorta is filled with thrombus. However, this is not the case. This patient had a very ectatic aorta, and the mid portion of the aorta was not visualized since it was out of plane. So you can see here as you go from cephalad to caudal direction, you have the anechoic lumen here. Now you have this what appears to be fill-in, and it's because you're sidewalling the vessel due to the ectasia, and then more distally you can see that the lumen is once again visualized. Now note in this clip of a patient with an atherosclerotic aorta that greater degree of transducer manipulation here was again required in order to scan the aorta. So you want to be able to work on this rock and glide technique early in your scanning career because it's important, because mastery of these types of hand skills will allow you to perform more advanced bedside ultrasounds. Now, we're not just talking aorta here, we're talking vascular access, gallbladder, renal, musculoskeletal. So these are the types of hand control drills that are essential for you to master in order to continue to improve in your ultrasound performance skills. On this proximal sagittal image of the abdominal aorta, the transducer indicator is directed towards the patient's head. The blue dot on the transducer corresponds with the blue dot on the image here. The liver is used proximally as a sonographic window. The transducer is going to be placed in the subxiphoid space. The first branch coming off anteriorly is going to be the celiac axis, and the second branch coming off anteriorly is the SMA. Remember, the renal arteries come off on the side, usually within about 2 centimeters of that SMA takeoff, and therefore will not be seen on the sagittal image. Keep this point in mind regarding the relationship of the SMA and the renal takeoff, since we will be talking about this again in the interpretive video. But to just go over the orientation here, this is going to be the anterior field, this is going to be posterior, this is going to be cephalad, and this is going to be caudal. And here you've got your aorta, and here you've got the liver that's being used as a sonographic window. On this video of the proximal aorta, note the presence of the pulsations. Again, note the presence of the celiac axis and the SMA, confirming that this is the aorta. Again, note, the liver is being used as a window. This is the patient's anterior, this is patient's posterior, this is head, this is foot. Here's the indicator marker here. That corresponds with the indicator marker here. The indicator in the sagittal plane is always directed towards the patient's head. Now, even though you cannot directly identify the renals on the sagittal view, you can estimate the takeoff of the renals since they occur in the vast majority of patients within 2 centimeters of the SMA takeoff. So here you have the takeoff of the SMA. Now, if we measure down, here you can see the caliper markers here. If we mark down about 2 centimeters from here, we would know that the renals would be coming off on the side somewhere between here and here. This is a quick way to aid in identifying whether an aneurysm is suprarenal, juxtarenal, or infrarenal, and we'll be going over this further in the interpretation videos. As you move distally to the mid-aorta, you will lose the ability to use the liver as a sonographic window. You can see right there that the liver is now no longer being used, and therefore you're going to become susceptible to bowel gas obscuration of the aorta. You can see at this point bowel gas gets in the way. It is at this point that you will need to apply gentle transducer pressure in order to maintain visualization of the aorta. Note in this patient that visualization of the aorta is lost once the mid-aorta is reached. It's vital that all efforts to visualize the aorta in this region are made, since over 90% of AAAs are infrarenal. If all you see is the proximal aorta, it's an indeterminate study. Now note in this patient that visualization of the aorta is maintained as the mid and distal aorta is scanned. Note that the aorta will taper and become more superficial the more distal you go. So note that when you get to this point where you lose the liver as a window, you're going to have to displace the bowel gas, and that means gentle transducer pressure, and this will help you to maintain visualization as you go into the more distal area of the abdominal aorta until the bifurcation. As you scan in the sagittal plane, it is easy to slide onto the inferior vena cava if you take your eyes off the screen. You do not want to start on the aorta, end up on the inferior vena cava, and miss an abdominal aortic aneurysm. So remember, keep your eyes on the screen. Note in this scan that by gently sliding the transducer to the patient's right, you go from the aorta to the inferior vena cava. This may seem like a very unlikely mistake to make, but is something you need to be aware of, especially during the early stages of your scanning career. You want to, as little as possible, rely on looking at your hand in terms of placement on the body to guide which way you want to move for corrective maneuvers. You want to use what you're seeing on the screen to help guide you. Therefore, you're going to very rarely miss pathology by turning your head away, nor would you make a simple mistake like this from going from the aorta. The aorta is going to be followed through the bifurcation. Topographically, this occurs at about the level of the umbilicus. As you approach the distal aorta, the aorta will become relatively superficial. In order to optimize image visualization, you can decrease the field of depth so that the aorta remains centered on the screen. Once the bifurcation occurs, the common iliacs will begin to dive posteriorly, as can be seen here. You can see that it becomes more superficial and then it begins to dive posteriorly after the bifurcation has occurred. Since the common iliacs come off in a side-by-side fashion, you will not visualize both completely in the sagittal plane. This is best done in the transverse plane. Now, the bifurcation can be imaged also in the coronal plane. This is usually obtained with the patient in the left lateral decubitus position. The transducer is going to be moved towards the patient's right from the sagittal plane. So you begin here in the sagittal plane, you move the transducer towards the patient's right, and you visualize the aorta in a coronal plane. And what that's going to give you is this view right here, where you're able to then see both branches of the common iliacs as they come off. Now, this is a nice view, but the transverse view will also supply you with adequate information regarding the bifurcation and is usually easier to perform in the acutely ill patient. The aorta is measured in both sagittal and transverse planes. These two measurements should be complementary. The aorta is going to be measured from the outer wall to the outer wall, and the aorta can be measured in multiple locations depending on the location of the pathology. When you do a sagittal measurement, you should obtain the image as close to midline of the vessel as possible. If you go off too far to the side, you're going to underestimate the AP diameter of the aorta. Here you can see an AP measurement in the infrarenal region here. You've got the caliper anterior and then posterior, and then the measurement here is 1.81 centimeters. So to just reiterate the point, measurement A would underestimate the true AP diameter of the aorta because you're sidewalling the vessel, whereas B would represent a true estimate of the AP measurement of the aorta. Okay, now let's put it all together. On the sagittal aortic ultrasound exam, you're going to start high up in the subxiphoid space. Indicator is going to be pointed towards the patient's head. You're going to move the transducer down using a rock and glide technique until the bifurcation is seen. The initial image here, you've got anterior, posterior, head, and foot. You've got liver as a window. Here you've got the thoracic aorta. You're turning into the abdominal aorta here. You've got the celiac axis, the SMA. You're going to see the aorta through the rock and glide technique and gentle transducer pressure into the mid and distal region. It becomes more superficial, so decrease your field of depth and follow it until the bifurcation. That is the complete abdominal aortic sagittal exam. This completes the sagittal abdominal aortic exam video. Now move on to the next video. I'm Dr. Robert Jones, and in this lecture we will be covering how to perform the transverse abdominal aortic ultrasound exam. Exam essentials were covered in detail in the sagittal abdominal aortic ultrasound exam video. However, to briefly review, remember, the patient should be in a supine position for the exam. Due to the field of depth needed to visualize the abdominal aorta in an adult, a 2 to 5 megahertz transducer is needed. Ideally, a large footprinted curvilinear transducer should be used since this will aid in displacement of bowel gas. However, a small footprinted curvilinear or a phased array transducer can also be used. Gentle transducer will be needed during the examination in order to displace bowel gas. And lastly, the exam can be initiated in either the sagittal or the transverse planes. It's up to the sonologist to to decide which one they want to begin with. It's really a matter of personal preference. Let's look at exam orientation. The image is as follows. You've got the transducer with the indicator directed towards the patient's right, so that will give you the following image. You've got anterior, posterior, patient's right, and patient's left. So you've got the liver here off to the left of the screen, which is the patient's right, and that's being used as a window. Here you've got the aorta, here you've got the inferior vena cava, and you've got the vertebral body posterior. In the following slides, we will cover key transverse images that you will encounter during the scan. While it's not essential that you can identify every single structure on the images, it's important to identify some of these key transverse images, since it will help you to know, whether you're suprarenal, renal, or infrarenal in terms of your location. So the exam is initiated with the transducer in the subxiphoid space and the indicator directed towards the patient's right. The liver again is going to be used as a sonographic window, and you're going to set your field of depth so that the vertebral bodies are visualized initially. Once identity of the aorta is confirmed, then you can adjust the field of depth so that the aorta is centered on the screen. If the liver does not provide a sonographic window, then you're going to have to gently apply transducer pressure in order to displace bowel gas if you're not able to visualize the aorta. Here you can see high up there, you've got the liver as a window, aorta, inferior vena cava, vertebral body. Now the first branch that will be visualized coming off of the aorta is going to be the celiac axis, and you can see that here in this short axis transverse image. It is referred to as the seagull sign in the short axis, with the hepatic artery being the wing going towards the patient's right, and the splenic artery being the wing going to the patient's left. At this level, we are still suprarenal or above the level of the renal artery takeoff. So there's aorta, celiac axis, inferior vena cava. In this video, the proximal aorta is visualized and the celiac axis is also visualized. To the left of the aorta on the screen is going to be the inferior vena cava, and you can also see some of the superior pole of the right kidney, posterior and lateral to the inferior vena cava. And these again are images obtained in the suprarenal region of the aorta. Now moving the transducer in a caudal direction from the celiac axis takeoff, you will next encounter the takeoff of the SMA. This vessel takeoff is also on the anterior aspect of the aorta, just like the celiac axis. What you'll see on the transverse view is an echogenic ring surrounding the anechoic SMA. You can see the SMA is anterior to the aorta, and here you can see the vertebral body, and to the left of the screen you have the inferior vena cava. Okay, so let's take a look at this video here. Again, it's a transverse view, so you've got the indicator here, so this is patient's right, patient's left, anterior and posterior. You've got liver, here you've got pancreas, here you've got the SMA, you can see the aorta, you can see the inferior vena cava, and you can see some of the left renal vein coursing over the top of the aorta here. Moving the transducer in a caudal direction from the SMA takeoff, you will next encounter the takeoffs of the renal arteries. The takeoffs occur on the side of the aorta. So here you can see the aorta here. You can still see the SMA coming over the top. You've got the vertebral body posteriorly. And here you can see coming off of the side of the aorta, this would be the right renal artery here. Note that we're still able to use in this patient the liver as a sonographic window at this level. Moving the transducer in a caudal direction from the SMA takeoff, you will next encounter the takeoffs of the renal arteries. The takeoffs occur on the side of the aorta. So here you can see the aorta here. You can still see the SMA coming over the top. You've got the vertebral body posteriorly. And here you can see coming off of the side of the aorta, this would be the right renal artery here. Note that we're still able to use in this patient the liver as a sonographic window at this level. In this video, the transducer is moved in a caudal direction from the celiac axis to the renal artery takeoffs. You can see that the transducer placement here is initially over the celiac axis, and it will end off at about the level of the renal arteries. So you can see starting off here, you've got your celiac axis here, you've got the aorta, inferior vena cava, and your vertebral body. You can see as we move down, SMA, left renal vein, right renal artery coming off. To emphasize the importance of identifying the relationship of the aorta to the vertebral bodies, in this video we note two vessels early on. The novice scanner that performed this exam thought that these two vessels represented the inferior vena cava and the aorta. Note that the field of depth in this video was too shallow, and these vessels that were initially thought to be the aorta and the IVC were actually the superior mesenteric vein and the superior mesenteric artery. As the field of depth was increased, note that you can see here's the inferior vena cava, the aorta, and there's the vertebral body. So remember, give yourself enough field of depth in the beginning so that you can confirm the relationship of the aorta to the vertebral body. Then you can decrease your field of depth. Note on this video that the abdominal aorta will become more shallow in the mid to distal region, so you can decrease your field of depth. Note here that we're not using the liver any longer as a sonographic window, so transducer pressure is going to need to be applied. You can see here, as we move more distally, the aorta becomes more shallow and superficial, and then it goes into the bifurcation. So again, notice it's becoming more shallow, it begins to taper off, and then it bifurcates. And this is about at the level of the umbilicus. So note in this video, again, at about the level of the umbilicus, the aorta is going to bifurcate into the right and left common iliac arteries. This can be easily visualized on the transverse scan. It's important to remember that since some patients can have isolated iliac artery aneurysms, the common iliac should be followed as far caudal as possible. Now the aorta is going to be measured from outer wall to outer wall. This is particularly important when atherosclerosis and thrombus formation is present. You do not want to measure just the true lumen. You want to measure from outer wall to outer wall. It's important that the measurement should be performed with the transducer as close to perpendicular to the long axis of the aorta as possible. You can see here that measurement A would be a true representation of the short axis of the aorta, since you are perpendicular as close as possible to perpendicular to the long axis of the aorta. Whereas in B, you can see that you're actually in an oblique plane, so you're really going to be overestimating the size of the aorta. So you can see that there are potential measurement errors, either from the sagittal plane or from the transverse plane. So you want to be careful that you measure sagittally as close to the midline of the vessel as possible, and in transverse that you're as close to perpendicular to the long axis of the vessel as possible. Okay, now let's put the transverse view together. So the exam is initiated high up in the subxiphoid space, transducer indicator towards the patient's right. You're going to try and stay as close to perpendicular to the long axis of the vessel as possible, and then you're going to slide in a caudal direction until you reach the bifurcation. If possible, remember to scan the iliacs as far caudal as possible, since isolated aneurysms can occur. So here's your initial view. You've got anterior, posterior, patient's right, patient's left, inferior vena cava, aorta. There's liver as a window. As you move down, there's vertebral body, there's aorta. Notice that it's becoming more superficial, so you can change your field of depth. You no longer have the liver as a window, and there's your bifurcation. So let's summarize the key points of the transverse exam of the aorta. First, use gentle transducer pressure to displace bowel gas. Next, make sure that you provide adequate field of depth early on so that you verify that the vessel you're scanning is indeed the aorta. Make sure that you scan all the way through the bifurcation. And lastly, measure the aorta in both the AP and transverse planes. This concludes the abdominal aorta transverse scanning video.